Jangaya. My patient is 36-year-old male Jangaya, resident of Khammam, who is a graduate, worked as supervisor. He is a post-live related renal transplant. Now admitted now with chief complaints of oral ulcers and pain during swallowing with for 1 day and increased serum creatinine. He was admitted 20 days back. So now I would like to take back my history to 2018. When he was 31-year-old, he was apparently normal till 31 years of age. One day he developed headache associated with blurring of vision, which was occipital headache associated with vomitings, non-projectile, non-bilious. There were no history suggestive of focal neurological deficits at the time of presentation. For these complaints, he visited a local hospital and found to have a BP of 200/100. He was admitted for 1 day and some IV injections and oral medications were given, and no blood or urine tests were done at that time, and was discharged on oral medications. During the next 1 week, he was having intermittent headache and visited the same hospital with continuing the medication after 1 week. And again he found to have a higher BP of 180. There he was referred to, they done some blood tests and urine tests and found to have a serum creatinine of 1.8 and referred to a nephrologist. Referred to a other higher center, but he is not aware if he is a nephrologist or not, ma'am. At this point, no history of vomiting or diarrhea, no history of decreased urine output, or no history of red color urine, or no history of facial puffiness or pedal edema. Patient did not notice any proteinuria, and no history suggestive of connective tissue diseases like joint pains or rash or oral ulcers. No history of alternative medication usage or NSAID abuse. At the time he was given oral medication and found to have a kidney dysfunction and advised regular follow-up. At this point, he was not aware of renal biopsy or loss of blood or protein in the urine. From that visit to next 4 years, he was using antihypertensive tablet. He remembered Telma 80 mg once daily, but he did not go further follow-up. He lost a follow-up and no other blood tests or urine tests were done for the next 4 years, and intermittently used to have headache for like at least 4 or 5 months like that. When BP was taken, it was around 160 to 170. Used it at double tablet of BP tablet and continuing the tablet same. Did not visit any other hospital for the next 4 years now. Then otherwise he was asymptomatic. Then November 2022, 4 years later, he presented to hospital with history of nausea, vomiting and generalized weakness and decreased appetite and pedal edema with duration of 10 days, and found to have serum creatinine 15 and advised hemodialysis. So patient visited NIMS for further management. Hemodialysis was initiated via right IJV non-tunneled catheter. Serial 3 sessions of hemodialysis were done, and on ultrasonography patient was told to have small sized kidneys and renal biopsy could not be done, and discharged on day 5 and advised to continue hemodialysis. He underwent twice weekly sessions of hemodialysis at NIMS with access initial 2 months were IJV non-tunneled catheter with no associated history of CRBSI, followed by access was left radiocephalic AV fistula. No history of intradialytic hypotension or hypotension. There is history of 2 blood transfusions in the initial 2 months of dialysis vintage. No history of suggestion of infectious tuberculosis or hepatitis C or hepatitis B. His intradialytic weight gain was 2.5 kg. No hospital admissions during the dialysis vintage, and residual renal function was 250 ml. And he was vaccinated 4 doses of hepatitis B during the dialysis period. Then April 27, 2023, after complete workup, he was undergone live-related ABO compatible renal transplant with mother as donor. Age was 60 years with history of hypertension for 6 years. Well controlled with one drug. He remembered was Telma 40 mg, and her serum creatinine at the time of transplant was 0.9. And as per patient knowledge, intraoperative period was uneventful, no history of blood transfusion, and he was not aware of any inductive agents given. He was shifted to post-operative ward after surgery. He was told that he was having good urine output and good kidney function. First 10 days were uneventful. From day onwards, patient remembered that creatinine was increasing progressively over 3 days from day 10. Least creatinine he remembered was 1.3, then it increased to 1.9 when around day 13 renal biopsy was done, and patient was told that he was having rejection and he will require special form of dialysis like plasma exchange, and total 5 sessions were given on alternate day along with some injections. The sessions went uneventfully, and finally patient was discharged on day 27 with serum creatinine of 1.6 with urine output of 4 to 5 liters per day with immunosuppressive medications Visalone, tacrolimus and MMF. He was on regular follow-up after discharge, was doing regular blood tests and urine tests. After 1 week of discharge, he found to have asymptomatic increase in serum creatinine to 3 mg per deciliter. So he was admitted further. That was asymptomatic without no history of fever, vomiting, diarrhea or decreased urine output. On investigation, patient told that he has to decrease the tacrolimus dose, and some IV fluids were given during the hospital admission. After 1 week, he discharged with serum creatinine of 1.9. No repeat renal biopsy was done at that time. In the next 2 months, he was on regular follow-up, regular blood investigations and urine tests, and serum creatinine was fluctuating between 1.9 to 2.2. Otherwise, he was asymptomatic. Yes, total. Now he admitted 20 days back, that is 3.5 months post-transplant, with chief complaints of oral ulcers and pain during swallowing for 1 day, and increased serum creatinine to 3.2. Oral ulcers were painful and no other history of fever or vomiting, diarrhea or a decreased urine output, or no history of cough, breathlessness or pain abdomen. There is difficulty swallowing and pain during swallowing is the main complaint. On third day of admission, patient was undergone upper GI endoscopy and told to have some infection. Was started on IV injections. So he was taking injection from the last 18 days, and symptoms were improved after 3 days of starting the injections. That oral ulcers and difficulty swallowing, dysphagia was improved. And he told that serum creatinine was fluctuating during the hospital admission between 2.7 to 3.5 around, and he was told the repeated tacrolimus bloodly investigations were done, and TAC dose was progressively reducing during the hospital admission. Initially, at the time of admission, he was taking 2.5 mg per day. Now, latest he was taking 0.5 mg BD. Total 1 mg per day he was taking. And his latest creatinine he remembered was 2.5, that is 3 days back. Past history. No history of tuberculosis or epilepsy or bronchial asthma. No history of drug allergies or diabetes, hypertension. No childhood history was uneventful, normal birth weight. No history of recurrent UTIs or no history of double warding. Personal history, not an alcoholic smoker, takes mixed diet, bowel and bladders are normal. Family history is not significant, ma'am. Mother is only hypertensive, mother is the donor. He has 5 siblings, all are females, and no family history of renal disease in the family. Examination, he is conscious, coherent, moderately built and nourished. BMI was 22 kg per meter square. No pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, no pedal edema. Oral cavity present, no ulcers are there, ma'am, and no tremors, and there is good functioning left RCAVF is there. Systemic examination of abdomen, inspection shape of the abdomen flat, position of umbilicus is normal. Allograft scar is present at the allograft site. No visible other veins or pulsations. Skin over the abdomen normal, no flank fullness or hernial orifices normal. Palpation per abdomen soft, no tenderness or anywhere at allograft site, no hepatosplenomegaly. Palpable. No tenderness. Percussion normal tympanic note, no hepatosplenomegaly.
Into her oral cavity, she presented with some oral ulcers.
Yes.
Have you examined her oral
Now
cavity?
oral ulcers are not there, ma'am. Some hypopigmentation is there, but ulcers are not there. Yes, still he is undergoing. Yes, sir. Yes, sir.
Okay, you can finish your.
Other system examinations are normal, sir. So,
Summarize and
yes.
compare diagnosis.
This 36-year-old male with summarize. 36-year-old male diagnosed otherwise asymptomatic till 31 years of old. Yes, diagnosed with renal dysfunction. Presentation was hypertension with serum creatinine 1.8. With history of uncontrolled hypertension over 4 years, with the renal biopsy was not done. Then progression over 4 years to end-stage renal disease with serum creatinine 15. Initiated on dialysis with dialysis vintage of 6 months with history of 2 blood transfusions. Otherwise, no positive history during dialysis. Underwent ABO compatible live related mother as a donor, 60 years mother, hypertensive donor, well controlled on single drug. With immediate graft function, with early ABMR during day 12, with 5 sessions of plasma exchange, with history suggestive of probable CNI toxicity during the early 2nd month, with the persistent allograft dysfunction with fluctuating creatinine. Now probable infection with acute and chronic allograft dysfunction.
What is the likely infection now?
As oral ulcers are there, dysphagia is there, fungal infection is one possibility, ma'am, and viral infection with CMV is another possibility.
What viral infection causes oral ulcer?
Herpes labialis, herpes simplex.
Simplex. That is the commonest.
Yes.
Which fungus you are thinking of?
Candidiasis, oral candidiasis, progression to esophageal candidiasis. CKD transplant, ma'am, post live related renal transplant, native kidney disease presumed CGN with seen post early acute antibody mediated rejection, with seen post CNI toxicity, with now acute and chronic graft dysfunction, with probable infection, probable fungal or secondary viral.
Which virus are you considering?
Cytomegalovirus is one.
But why are you thinking of that?
Only dysphagia is there, sir. Otherwise,
Dysphagia?
3 months post transplant and high immunosuppression history suggestive of. Dysphagia is there.
Dysphagia so specific? Can happen.
Yes,
Dysphagia could even be candida.
yes. First difference is candida fungal, second is viral.
Is she a high risk candidate for CMV?
Yes,
You suspect a differential diagnosis of CMV?
yes, ma'am.
What are the points to suspect CMV here?
Here ABMR history is there and post plasma exchange and higher dose of steroid must have given, and based on sensitization history I presume inductive agents also must have given.
Okay.
And 3 months post transplant, two
Blood
blood
transfusion.
transfusion within 6 months of before 6 months of transplant.
Now you have graft worsening of her graft function along with this, isn't it?
Yes, ma'am.
And received some IV drug for the treatment.
Yes, ma'am.
Or this may be the
CMV.
reasons why you suspected a CMV.
CMV.
That
Yes, yes.
is the strong reason which leads you to CMV more than anything else.
Yes.
risk factors are there, all right. Injection for 18 days,
Yes, sir.
that is the first thing you should say.
If that patient came to you at 31 years of age with hypertension of more than 200, how you should have approached that patient?
Hypertension and
Do you think this is a primary or a secondary hypertension at that point?
presentation before 30 years is primary hypertension, secondary hypertension.
Mm-hmm.
Patient is around 31 years at presentation.
Mm-hmm. So it is not
Associated
secondary.
argon damage here, creatinine was 1.8.
Okay.
So
So presenting with a target organ
Target
dysfunction.
organ
3.
dysfunction is there. Age more than 55 years, presented with
Now
pulmonary
for
edema.
this patient, points in favor of a secondary hypertension.
ACE and elevated serum creatinine.
Okay.
Uncontrolled hypertension.
Hypertension at presentation of more than 200. Mm. He had some diminished vision also, possibly a grade 4 retinopathy. Isn't it? What are the other features of a secondary hypertension, to suspect a secondary hypertension?
Recurrent history of pulmonary edema.
Okay.
Age more than 55 years presentation.
Yeah.
55.
Hmm.
55. And refractory resistant hypertension
Resistant
requiring
hypertension.
multiple antihypertensives. Resistant hypertension is on 3R, requiring 3 or more drugs to control hypertension.
Definition should be the definition.
Definition.
Ah.
Blood pressure of
How will you define as per ISH 2020 guideline? Hmm.
More,
a blood pressure of.
more than
I'm giving you the read.
more than 160,
Hi.
140,
Hmm.
40 by
90, even with the 3 or more
over
drugs.
9 period.
Maximum dose or maximally tolerated doses of 3 antihypertensives and
Diuretic.
one should be a diuretic. All these definitions you should know. What is refractory hypertension then? Both are the same or different?
Different.
So what is the difference?
Uncontrolled even
Hmm? What is refractory hypertension?
Uncontrolled hypertension with more than five antihypertensive agent. One of them must be diuretic and mineral
Other
water.
should be mineralocorticoid receptor antagonist. 5 antihypertensive should be there. One should be a diuretic, other should be a mineralocorticoid receptor. Still blood pressure uncontrolled is defined as overall what percentage of hypertension is refractory to treatment?
5 to 10%.
3%. Refractory hypertension is roughly 3% only. Okay.
So, coming back to the question, when you had seen the patients at 30 years, 31 years, how would you have evaluated system? What would you have thought of and how would you have evaluated?
creatinine presentation 1.8 ma'am. So urine test to know the glomerular cause of kidney disease. See you
Now
urine
can that
examination.
1.8 milligram creatinine can be explained by her 200 millimeters of blood pressure?
Yes ma'am, malignant hypertension causing.
What is the cause of AKI in malignant hypertension?
TMA.
Secondary TMA.
TMA.
So you have to control her blood pressure and then reassess the
Renal
kidney
function.
Then continue with it.
Then other causes renovascular hypertension you have to evaluate. Ultrasound abdomen and renal Doppler.
Hypertension will present with 1.8. I mean, if once you have taken care of the accelerated hypertension, and then you are evaluating him. So you are thinking of renal artery stenosis, renovascular problem you said. What renovascular?
Renal artery stenosis.
You took
And other vasculitis, autoimmune.
renal artery stenosis, you took
At this age, vasculitis are common, ma'am. 31-year-old.
vasculitis.
To produce renal artery stenosis, what should be the type of vasculitis? Small vessel, medium vessel, large vessel?
Large vessel vasculitis. Takayasu arthritis.
Arthritis. Hmm.
And elderly, pars immune, other generalized vasculitis can be there.
Okay.
James.
Arteriosclerosis.
Atherosclerotic. Yes.
This patient after 4 years came back with 15 milligram creatinine and bilaterally contracted kidney.
Yes.
So at this point, what is your thought process? Cause of hypertension?
Cause of hypertension, probable CGM.
Probably a renal parenchyma
Renal
and
parenchyma.
hypertension and chronic glomerulonephritis. Okay.
Clinically, how do you differentiate between a glomerulonephritis and an interstitial disease?
Urine output will be preserved in interstitial nephritis. Even polyuria and nocturia can be there in interstitial nephritis, sir, and more prone for anemia, early anemia and interstitial nephritis. And presentation with fluid overload hypertension is more in chronic glomerulonephritis. And proteinuria, hematuria, glomerular hematuria, proteinuria, and more than 2 grams.
Proteinuria being significant.
More than 2 gram proteinuria is glomerular proteinuria, 24 hours. And dysmorphic RBs, presence of dysmorphic RBs indicates glomerular cause.
If there is some,
Yes.
what percentage of RBCs should be dysmorphic?
40% of dysmorphic.
Maybe 80 to 70 is indeterminate.
More than 70 is considered. What are the other features of glomerular hematuria other than dysmorphia? Which is the pathognomonic feature of glomerular hematuria?
RBC cash.
RBC
Even
cast.
single RBC cash is significant.
Okay,
And the 5% acanthocytes.
good.
That sediment should be taken and put on a slide manner. Covered with cover slip of 1 into 1 centimeters. RBC cash should be checked for on periphery of the slide.
What are these casts?
RBC is packed up with Tamhasville protein.
RBC is packed with the Tamhasville protein or Tamhasville?
Reverse.
It will pack the RBC, Tamhasville protein.
What kind of microscope you use for acanthocytes?
Phase contrast.
Have she understood?
Now, coming to the rejection, the transplant, you said that biopsy was done. Do we know the biopsy report? We don't know that.
Patient told it is rejection and
Only that much. Was it antibody mediated or not?
because plasma exchanges were done, I presume the ABM. Yes.
So what are the features of ABMR biopsy? How do you diagnose it?
Yes, sir. Vascular, microvascular inflammation should be there. Glomerularitis or peritubular capillaritis. Arteritis, intimal or transmural arteritis can be there. And TMA can be there, TMA, otherwise no other cause can be found, and acute tubular necrosis can be. C4D positivity in the peritubular capillaries. Linear strain.
How do you stain for C4D?
Immunohistochemistry or IF method is there, sir.
IHC is immunohistochemistry.
Yes.
Or
IF method.
IF.
Yes.
C4D is a participant of which pathway of complement?
Classical component.
Why you are not looking into the glomerular capillaries for C4D? Why it is the peritubular capillaries?
C4D glomerular will be usually positive or
Usually
recurrent.
glomerular C4D. In which situation you can have glomerular C4D?
Recurrence.
Where usually you see that?
Recurrence of glomerulonephritis.
Lupus. And the vascular pole in glomeruli, you can have, even normal glomeruli can have some form of C4D. Why there is no C4D within the glomerulus in ABMR? Anybody? Are there any other factors which removes these complement components within the glomeruli? Hmm? There are some anti-complement deaccelerating factors and other things within the glomerular, so they wash away the C4D. Now, if you have no C4D available, can you do C3D?
Yes, ma'am. C3D also indicates the activation of the complement.
Where it is useful in the clinical scenario. You are looking for specifically asking for C3D. In which situation?
ABO incompatible.
ABO incompatible,
transplant will
where
be-
C4D will be even otherwise will be positive, isn't it?
Yes.
Now, why she developed ABMR according to you?
Saliva-related donor,
Yes, ma'am. Here two sensitization history is there with two blood transfusions,
Mhm.
and donor age is 60 years and
Mhm.
recipient age is 30 years. Elderly donor can receive.
Young recipient, elderly donor are risk factors for ABMR, isn't it? Okay. What are the other factors during the dialysis period you are interested in
Blood
discussing a
transfusion.
transplant case?
Blood transfusion history for
One.
sensitization.
how
Two.
does blood transfusion influence graft?
Because patient will be exposed to more other HLA antigens, so preformed antibodies and memory cells can be there. After transplant, activation of cells and formation of antibodies, and ABMR can trigger ABMR.
Have you heard of donor specific transfusions, DST?
Same.
Donor
blood
specific
transfusion.
transfusions. It was practiced
Long ago.
long ago, before CNI era.
Really, since you may not have been born then.
Yeah. Likely.
I never heard of this DST.
But
You are trying to induce tolerance in the recipient by giving small doses of antigen of the donor. Hmm? Okay. Now, what are the other dialysis? During dialysis, what are the other factors?
infections, hepatitis C, hepatitis
Okay,
B,
viral transmission,
tuberculosis,
tuberculosis,
reactivation can occur, and
Okay.
cardiac status,
Cardiac status.
hypertension, hypertension.
Hmm.
Dialysis vintage also long term.
Episodes of CRBSI.
CRBS.
Yes, dialysis vintage. These are the factors we are interested in a pre-transplant
Yes.
patient. Now, do you think his antibody mediator rejection has responded to your plasma exchange and IVIG?
Serum
What is the
creatinine-
definition for response to treatment in ABMR?
The creatinine nadi should come down to within 30% of previous baseline nadi
By?
creatinine.
By? What should be the duration? Duration for TCMR, for ABMR? Resistant TCMR, how will you define?
Resistant TP, 1 week is for resistant TPMR, even after
Fifth
5
day.
doses.
5 days of
5 doses of
methylprednisolone.
methylprednisolone.
Creatinine should come down to
Within 30% of.
come down to 10% of baseline. ABMR, at least 30% of baseline within 3 months. Then only you can say this is a resistant ABMR or a resistant TCMR.
Tacrolimus level would you maintain in a transplant basis according to the immunologic risk? And at
First
various
three-
times following.
First 3 months it is 8 to 12 nanogram per ml, sir. For high immunological risk, higher side will keep. And next 3 months it is 5 to 8. After 3 months it is 5 to 8 nanogram per ml. High risk patients will keep on higher side, and low risk patients we can decrease to lower side of the level.
And if
Both with induction, without induction, it's the same level.
Without induction, higher, little higher level.
it works both ways. With induction, you're giving induction because of a high risk.
Yes.
So maybe you can use a slightly lower dose, but that's also relative to because you have a high immunological risk.
Yes.
Induction will always take care of the early post-transplant. If you are not able to maintain adequate levels of CNI or say tacrolimus with good dose, should you do something else to increase the levels?
Other than increasing the
dose.
dose, enzyme inducers, other enzyme inhibitor drugs can be given,
Which one?
right? Fluconazole, erythromycin,
What is actually
mTOR,
used?
mTOR inhibitors, MMF.
MMF you are already
Yes,
giving in
yes,
any
sir,
case.
yes.
What else do you actually use practically?
Calcium channel blockers,
Which calcium
Which
channel?
one? Yes, you can use.
nifedipine, dietary.
Yes.
How much level will increase with diltiazem? 30%.
Yeah,
More than that, more potent than that, better than that. Ketoconazole.
Ketoconazole, 100 milligrams a day. That can increase by even 50-60%.
60%.
So that is actually done. It reduces the cost also. And you know, if you are using large doses of tacrolimus and yet you are not maintaining the level, then one option is to do this. What is the other option? You increase the dose, of course, that is a different thing. You don't want to increase the dose beyond a certain limit. So what is the other option then? You know, you will actually face all these problems
Yes, sir. Yes.
in your practice. You can use some other CNI,
Adding changing over to cyclosporine.
switching over to cyclosporine. That is the other option. If you are not getting good levels with this, you will go on to cyclosporine. It's not the first choice now, but sometimes you have to do that. How does MMF act? What is the mode of action?
Anti-metabolite.
Yeah, it's an antimetabolic.
Mechanism of action.
Where does it act? In the sense that
Which
G
enzyme
phase,
does it block?
G1 arrest.
Which enzyme does it block?
Adenosine monophosphate dehydrogenase inhibitor. So you must remember all this. Do you measure MMF blood levels?
Area under curve should be measured.
Yeah, if at all you measure, it's done only as a research tool. Sometimes in pediatric cases you may do it. Otherwise it's not done anywhere. Yeah, there are a few exceptions, yes, but otherwise they do, yes. And what are the important drug interactions of azathioprine in case you do use it?
You should not use this drug along with azathioprine.
One is very important.
Very important. Allopurinol.
Allopurinol,
Yes.
xanthine oxidase
Inhibitor.
right?
Severe leukopenia.
Yeah, because they are involved in the metabolism of azathioprine. So if you block that enzyme,
Drug level will increase.
drug levels go up. and
Bone marrow
bone
suppression.
marrow
Suppression.
suppression. So never combine.
If the graft biopsy shows a glomerulitis, what is its importance? A single mononuclear cell infiltration within the glomeruli. What else you should look for?
Tubulitis should be looked for to know the
Rule out
BCMR.
ABMR, you look for peritubular neutrophils, capillaritis.
Capillaritis.
Then there are no evidence of ABMR. So
Recurrence of
look for vasculitis. Severe type 3 TCMR is also can be associated with glomerulitis. Third, what is the other reason for glomerulitis with rejection? Always look for CMV. CMV. Whenever there is glomerulitis. Rule out ABMR,
CVM.
look for vasculitis, V3 or V2, and rule out CMV. What do you mean by expanded criteria donor? This is related to live donor or deceased donor?
Deceased donor.
Define expanded criteria.
With the KDPI more than 85, age more than 60 years.
Definition of expanded criteria. Where does the KDPI come? The
Age more than 60 years.
age more than 61.
Serum creatinine more than 1.5.
If the age is between 50 to 59,
Serum creatinine more than 1.5.
Ah.
And cause of death CVA, stroke.
and 2 out of 3 should be present.
Yes,
50 to
yes.
59, 2 out of 3. Hypertension, creatinine 1.5,
1.5.
and cause of death is CVA. Any two. With age between 50 to
50 to
59.
59.
That is the definition for expanded criteria donor.
Can you take a diabetes as a donor? That is a
Yes, ma'am. Latest guidelines can take.
Hmm.
And the criteria is age should be more than 55 years and
Hmm.
duration should be more than 3 years. And other organ damage should not be there with no microalbuminuria and well controlled with HbA1c less than 7 or at least measured 3 times over the past 2 years.
Patient
And,
can be on
two
insulin.
oral, no, 2 oral, at least minimum only 2 oral antihypertensives maximum.
Hypertensive donor?
No, hypertension should not be there.
No, hypertensive donor, patient
Hypertensive.
donor with hypertension. What are the
Well
criteria to
controlled,
accept?
should be well controlled with one drug or combination of with
2
minimum
or
dose.
less, should not be more than 2 antihypertensives, and
No organ damage with no
Organ
hypertensive
damage means
retinopathy.
what?
No hypertensive retinopathy.
no
Cardiac,
LVH, no LVH, no retinopathy, no LVH. Okay.
But these diabetes guidelines, there is still some controversy. I don't think you should say that these are accepted.
individual rights.
Yeah, this is still, I think, the subject of discussion. The opinions may vary.
Previously it was a definite contraindication for donation, now that has been changing. That's
Some groups have, the OPTN has said that you can change it, but I don't know whether it's really justified or not. If you are faced with a diabetic donor, would you categorically state that you have no risk, go ahead and donate? I think very difficult.
Yes. One to 2 gram per kg total dose should be minimum 1 gram per kg. Per kg, 1 gram per kg minimum dose should be there to treat ABMR. 1 per kg, 1 to 2 gram per kg. Replacement dose is 400 mg per kg. Replacement dose is 400 mg after plasma exchange.
Yes, that is
Total dose is 400 to 500 mg per kg. To neutralize antibodies.
What are the features of, you told us about ABMR, chronic ABMR?
Chronic changes will be like interstitial fibrosis, tubular atrophy will be there, and glomerular, double contour of glomerular basement
What is
membrane.
that called?
when
Glomerular transplant glomerular. Yes.
What is the criteria of what?
how will you say there is transplant glomerulopathy?
Double contour of glomerular basement.
How much layers should be?
Minimum 2 layers.
Hmm? Tubular basement membrane?
5 or
7.
But that is
multi-layering
seen on-
of tubular basement.
Yeah.
That is seen on EM. Multi-layering of
Tubular
very
basement.
tubular
Basement membrane.
and there can be multiple arterial
Hyper.
fibrosis.
Chronic.
How to manage a chronic ABMR?
Chronic ABMR, baseline immunosuppression can be increased.
Means what?
What are the
If
risk
the-
factors?
Risk factors, oral previously low oral immunosuppression can be the reason for development of de novo antibodies and slowly damaging.
If the patient is not on steroids, steroid-free regimen, but
Risk.
restart steroids.
Yes, yes, ma'am.
Patient is on azathioprine for anti-metabolic,
Convert to
MMF. Level of tacrolimus,
should be maintained on higher side.
higher
12.
tac level of at least 8 to 10.
IVIG can be tried.
Any other drugs tried for chronic ABMR? What is the
Tocilizumab is IL-6 inhibitor to prevent the further antibody formation.
any trial with rituximab?
Yes, rituximab.
Trial, name of the trial with rituximab in chronic ABMR? Rituximab. Then with tocilizumab? Any trial with bortezomib? Borteject. Any new IL-6 antibodies has been under trial? That's now, I don't know, I can't even tell that.
So many.
Very difficult to tell that name. Say IL-6 antibodies. Just, what is the trial? Imagine. Imagine trial. According to the recent literature, what is the most common cause of late allograph dysfunction?
Chronic ABMR is the reason for it.
More than-
Previously it was thought at CNA toxicity.
Okay, now we are more worried about chronic ABMR, isn't it? Do you want to look at the DSA at this point of time?
Yes, DSAs will be there. But de novo DSAs are there, anti-plasma
If you have,
excited-
if you are doing a single antigen, which antibody against which HLA antigen you will look for?
DQ,
DQ?
HLA DQ.
Which DQ? Anti-DQ7. Why DQ7? Most polymorphic HLA antigen. So you look for anti-DQ7, which is the most common de novo DSA. Overall, what percentage of transplant patients develop de novo DSA?
25 to 60,
25 to
50%.
percent, roughly around 2% per year.
Okay.
What is the incidence of antibody to MICA? Less than 5%. Less than 5%. Can you have an antibody mediated rejection with negative DSA?
Yes, ma'am.
Explanations?
Non-HLA
Non-HLA antibodies. Then two.
Low false negative results can be there with
Very
DSA.
subclinical titers of DSA. 3. Severe rejection where the graft acts as a zinc, absorb all DSAs. C4D negative ABMR.
Class 2 DSAs, non-complement fixing can cause
Non-complement
C4D.
fixing antibodies.
Can cause C4D.
Then NK means cell mediated rejections. 3. When will you suspect 80 to 81 receptor autoantibody mediated ABMR?
Hypertension.
Severe hypertension,
hypertension
one,
with
two.
Volume overload
Two.
presentation.
Severe hypertension. 2. Vasculitis. Severe vasculitis in the biopsy. 3. DSA negative. These are the 3 features of AT1 receptor antibody mediate. What are the other non-HLA antigens has been identified in the transplant scenario?
MICA A, MICA B, anti-endothelial
Anti-endothelial cell,
Endothelial.
endothelial cell antibody, AECA, others, anti-perlecan, anti-agrin, several of them has been identified now.
The vascular changes of hypertension do you see in any cases?
Arterial hydronosis can be there, sir. And TM in malignant hypertension. And chronic changes, sclerosis, glomerular sclerosis. Intimal hyperplasia. Thickened.
What happens in malignant
TMA will
histology? What
Classical appearance
onion skin appearance of vessels
of which vessel?
afferent artery.
Which is the most commonly affected vessel in the kidney in malignant hypertension? Interlobular and afferent.
Petechial hemorrhages can be there. Flea beetle.
Supposing a patient who is 72 years old comes to me, he has CKD5, and he says he wants a transplant. She also has a donor. What would be your response?
Based on his general condition and expected life expectancy, we can proceed after ruling out all other cardiac causes and age-related malignancies. That is not a absolute contraindication for.
Supposing he is diabetic,
And other cardiac evaluation is the main thing in this.
yeah, so you can
Yes.
actually do a transplant in such recipients, although most of the time our reflex is
Yes.
to reject
Yes.
them.
Yes. Sir.
Mostly 95% of the time we say no.
Yes.
But if you look up the literature, there are series of small series of such patients. वो celebrities तो अलग बात है. So, but the literature does mention. And what are the results in them?
As normal,
To younger recipients.
similar results.
Similar results? No, not entirely. The short-term results, up to 2 years, patient and graft survivals are as good. But the long-term patient survivals are not that good because obviously age-related. They could develop cardiac or CNS complications or malignancy. So long-term results are not good. Short-term survivals are good. That's why they can consider we have excluded serious hospitals. That's correct. What cause of CKD is very important to exclude in this age group before going for a transplant.
TMA is one, C3 glomerulopathy, TMA, based on risk of recurrence in the transplant.
What else can recur?
FS, primary FSGS,
And say of 70 years.
70 years. Diabetic, malignancies,
But if they are not
Yes.
there, then
yes.
there is one thing which can cause the CKD also and cause problems again.
Post-transplant.
Your pre-transplant workup, that would be an important component. I think we have already asked the question earlier today. Did you do an electrophoresis?
Okay, sir, multiple myeloma. That's what malignancy I was meaning
Yeah,
that.
but
Yes, sir. Multiple myeloma. I should
It's a very
discuss.
wide
Yes, sir.
range.
Multiple myeloma.
Where it
If
can
you miss,
spread.
if you miss before transplant, then
Yeah, that would be a catastrophe.
yes, sir.
You'll be blamed
Yes,
for having missed that.
yes.
And very early post-transplant, you will get a recurrent.